We are so very fortunate to have the iconic and omnipresent Steve Love join us today. For those of you who don't know Steve, he's the president and CEO of the Dallas-Fort Worth Hospital Council. And if you don't know the Dallas-Fort Worth Hospital Council, it's an association of 75 hospitals in the North Texas region. Steve has been there for 13 years now in that role, and he has developed quite a reputation in the community for being a spokesperson on healthcare issues of all types. He's a native of Virginia, a graduate of Virginia Tech University, and prior to starting his career in the association business, he was a longtime CFO with both Triad Hospitals and Charter Medical. In addition, Steve is a radio personality, and he hosts a weekly radio show on KRLD. It's called The Human Side of Healthcare. I'd highly commend that to you. But more importantly, Steve is a sought-after spokesperson on healthcare issues throughout the community, and not just from a hospital perspective, but overall in general. And it's likely you've seen or heard from him during these challenging times and other challenging times. And also he's quite active during the state legislative sessions and speaks often and during that period of time. And last but not least, he's a great friend of the North Dallas Chamber of Commerce. He's always playing an instrumental role in the planning of our annual healthcare conference each year and moderates our panel each year. And we're just so pleased to know him. I just sent Steve a note recently. Steve and I have known each other for more than a decade. We're good friends, but I just sent him a note late recently, and it just basically said, have we told you lately how much we appreciate you and what an incredible community asset you are? So Steve, we're so fortunate to have you here today, and welcome.
Thank you. And thank you so much for those kind words. Really do appreciate it, Ken. And I really commend the North Dallas Chamber. I mean, to really have these types of meetings, and this is kind of the inaugural one. Who would have known that we were going to have the stay-at-home order that was going to be in place? But to everyone that's joined, I just want to say thank you. And I did want to give you a couple of updates related to what's going on, some of the things we're looking at, and where we think we're going. First and foremost, Ken is right. I've been in healthcare for a number of years. I am not a clinician. I am not a physician, but I do listen to them. And what we've got before us now, I have sat down with some of the infectious disease physicians, the public health officials, etc. So I'm going to talk a little bit about North Texas, but I know this is the North Dallas Chamber of Commerce, so I am going to give you a little more update related to the Dallas area. First, many of you've probably read, but let me talk a little bit about what we're facing with the coronavirus. First, the coronavirus actually is a virus that has been around for a long time. The common cold is a type of coronavirus. When you look at SARS, when we had the problem with SARS, that was a type of coronavirus. And when you get into MERS, which was the Middle East, it was a type of coronavirus. When this first came out, it was called a novel, a new coronavirus. It's since then been labeled COVID-19, which is the name it was given. When I sat down with infectious disease doctors, this is what I found out. First and foremost, this really goes through an intermediary. For example, when you go back to SARS, it really went through a bat. There was a bat that was infected, was the intermediary, and it came back to a human. The Middle East, MERS, actually went through a camel, and so the intermediary was a camel. I don't know what the intermediary is for this, and we're not sure either. That's part of the reason the research is being done. That's part of the reason that they hope to get a vaccine. Let me explain to you, though. You hear a lot about the vaccine. They may come up with a vaccine in 60 days, but then it has to be tested. It has to go through clinical trials. All of that will be expedited. But probably when I talk to infectious disease physicians, we're looking at 8 to 10 months at the earliest before we can get a vaccine. I'm getting a little feedback. Can y'all hear me, or is Liz? Is everything okay? Okay. One of the things that the infectious disease docs don't know the answer to is this going to be one and done? And by that I mean kind of like SARS. Or is it going to be like the flu, where it recurs every year? Now, we certainly hope it's not going to recur every year, but it's still a lot of unknown. So when you think in terms of this, it actually started as a pneumonia, and it started towards the end of December in China. And I know all of you know that it's grown from China until the World Health Organization has actually called it pandemic. Here are the issues we're dealing with. And I've sat down with epidemiologists. We don't really know how it's going to affect each country. By that, I mean in Italy, where it is spread rapidly, and there are many people that are losing their lives. In Italy, there are multi-generations that generally live in the same structure: the grandparents, the parents, the grandchildren. So a lot of people got infected quickly whenever it got into a household. Here in the US, that's a little different. But the problem is it can incubate in certain settings. Unfortunately, that's what happened in Seattle. In Seattle, in that senior living, in the skilled nursing, when it got there, it traveled quickly. The mortality rate was higher because of the age of the individuals. So let's focus now a little bit on Texas. What does this mean? In talking to the public health officials and spending a lot of time with Dr. Philip Wong, who's doing a great job running HHS here in Dallas County, the thing you really look for and worry about is community spread. You know, initially when it started in Collin County, the individual had traveled to California, was at a meeting. It could be traced where it was. We're now in a situation where it's spreading through the community and it's not travel related. This is where it can spread exponentially. And that's why, as we look at this, and then we look at New York, and I saw right before we started this broadcast where Governor Cuomo said they vitally need 30,000 ventilators for the state of New York. That's a lot of ventilators. That is quite serious. If you look at what's happened in Chicago, I talked to a good friend of mine who was a physician at Parkland, who subsequently went to Chicago. And he called me Sunday, and the governor of Illinois has put him on a task force. He told me they are really facing running out of supplies, running out of ventilators, all because of how fast this virus is growing. That's why here in Texas, this past weekend, well, let me back up a little bit. Y'all probably have seen me give interviews. When this virus really came to North Texas about 3 weeks ago, I said publicly, and it was very truthful, the hospitals are ready. We have looked at our inventory levels. We're very blessed that we have large hospital systems here that are part of major group purchasing. And so they upped their inventory. And so 3 weeks ago, it was pretty easy to say, we're ready and we're ready to take this on, and we feel fairly confident. What's happened since then? There have been more cases in Collin County, cases in Denton County. They're growing in Dallas County, Tarrant County. So we're now seeing community spread, and we're seeing the volume of increase. Admittedly, 1 in 5 people generally will be admitted to the hospital. Not everyone that's going to contract this will come to the hospital. But when they do come to the hospital, my discussions with the physicians is some, especially if they're elderly and especially if they have other underlying conditions like congestive heart failure, diabetes, and so on and so forth, it can turn quickly, and they may need to go to an intensive care or critical care bed. And as a result, they may need a ventilator. So it moves rapidly once you're at that point that you require critical care. We have seen an increase in this in the last 3 weeks. So we've worked with epidemiologists. There is an epidemiologist out of London. His name is Neil Ferguson, and he's with the Imperial University, and he has done a lot of work on COVID-19. He's done a lot of work with infectious disease, and he looked and projected based on China, based on Italy, on how he thought it would spread in the United Kingdom and potentially the United States. Also, COVID Act Now. You can actually go to their website, COVID, COVID Act Now, did work, did analysis, did modeling. I worked with some physicians here in Dallas County, and we actually took some of the information off of the CDC website, and we extrapolated it and applied it to the Dallas area and to North Texas. Each of these models had different input. Each of these models had different types of assumptions. So you're going to get different answers. All of them showed significant projected volume increases in the next 4 to 6 weeks in North Texas. For that reason, this weekend, the Dallas-Fort Worth Hospital Council raised its hand and said, even though up until now we have felt confident, as we look at these models, as we look at this increase or projected increase, we are going to be overwhelmed. We never said that we were going to run out of beds, but 2 of these models did show that potentially the state of Texas could run out of the current inventory of critical care beds that we have. For that reason, this weekend, I contacted my executive contact in the governor's office and urged on behalf of the DFW Hospital Council that we do a complete stay at home. Some people call it shelter in place. We prefer to call it stay at home order statewide. We also asked if we could remove some of the requirements for some of the nurses. We have nurses that graduate and they have to do clinical rotations. Some of those can be done virtually. Some of those have to be done in a clinical setting, such as a hospital. We aren't doing any of those now because even those student nurses would have to put on PPE, personal protective equipment, because they're going through a learning process. Well, we're trying to conserve our PPE, so we've stopped all of those clinical rotations. We asked the governor, would you waive that requirement so these individual nurses could get licensed and we could add them to our workforce? To his credit, he did. He did announce on Sunday he was waiving those requirements, and we were very pleased. The other thing we asked for is a complete 100% pull down of all federal aid that we could possibly get to help us in this situation. And he assured us he would do that. Now, he did not feel comfortable issuing a statewide order. So what's happened? Well, you know, Sunday night, the county judge and for Dallas County and the mayor, Eric Johnson, jointly issued a stay-at-home or shelter-in-place order. I will tell you that San Antonio has done it, Austin is doing it, Harris County is now doing it. This morning, Tarrant County and the mayors from Fort Worth and the mayors from Arlington, all three said they were going to put a shelter-in-place or stay-at-home order. Collin County has done it. So we're gradually piecemealing doing this. The sooner we do it, the better. Why are we so adamant about we need to do a stay-at-home order? Going back to those models that I talked about, they showed if you did certain things like social distancing, maybe telling people don't gather in large crowds, it has an impact. But if you actually stay at home, it has a much bigger impact. So the hospital council, through our hospitals, thought if we can stop the spread of the infection, we're going to stop the people that die, at least reduce the number of people that die, and we're going to protect the residents of Texas and protect our first responders and our healthcare workforce, which is really also a strain. We talk a lot about personal protective equipment, surgical masks, ventilators, but your workforce is key in the treatment of this type of infection. And we've got to keep our workforce healthy. If we have workforce members come down with this and they have to be quarantined, we're going to lose people from the workforce. Many are working extra hours. Many are beginning to get burnt out. So look at what's happened in Seattle. Look at what's happening in New York. Look at what's happening in Chicago. Why do we think that would not happen here? The healthcare professionals think it could happen here. That's why we don't want people to panic. We're not raising and ringing the alarm bell. We're raising our hand and saying this is urgent. We need to address it. All of the stakeholders, the citizens, all of the people that are healthcare workers, the first responders, the religious leaders, the chambers of commerce, all the business leaders, we're in this together. We've got to work collaboratively. We've got to work in a fashion that we flatten this curve. You keep hearing about flatten the curve. We're talking about the demand curve, that surge that potentially could happen where we would have to go into emergency management situation. We are working on those contingency plans. We, the hospitals, work with all the health departments in all the counties. We work with all their emergency management people. We have backup plans if we had to call in FEMA. We also could put up tents in a 24-hour period. We're looking for an inventory as we speak. We're putting together a list of vacant hospital space that potentially could be used if needed. And we're looking at ways that we can step down some of the people maybe in ICU that aren't with the COVID-19 virus. They're there for another reason, but maybe step them down to a different level so we can use that bed. Not in any way trying to scare anybody here, not in any way trying to panic anybody, but we are now entering that increased volume potential surge. It's beginning to tax our workforce, our employees. We're having to really be judicious on our medical supplies, including surgical masks, and we're having to do everything we can to preserve. Many of the community leaders have responded so well. I had people call me and say, I'll retrofit my mattress factory so I can make surgical masks. That's all well and appreciated, and we're going and looking at all of that, but you still have to meet the medical specifications and the FDA requirements, because you don't want to have a homemade surgical mask that would still allow the patient or the worker to get infected. So we're having to be very careful as we do that. But we want to thank the community for your support. We want to thank the community for the overwhelming response. But one of the best things the community can do is to abide by the stay at home, do everything we can to keep from communicating this, because the public health of the community is an integral part of all of us working together. One of the things that really makes it serious in Dallas is we have the highest uninsured rate in the state. So many of the people may not have gotten their flu shot. Many of the people may not have seen a primary care physician. Many of the people may have been afraid because of financial reasons to seek medical help. So we have a group of population coupled with our homeless population that if they got infected, the disease could spread rapidly in that population. And then you have to have alternative plans, especially for the homeless, because even if you treat them and they don't need to be hospitalized, and you say go back home, they don't have a home to go back to. You've got to have some way to help quarantine them until they get through that episode of illness. So it's very complicated. It's going to take all of us working together. But I want to thank the North Dallas Chamber of Commerce for at least allowing us to explain why this is so important and why we really have got to do everything we can to flatten that curve so we don't spread this illness. Ken, I probably talked longer than you wanted, but I'll stop there.
Steve, as always, you're quite profound and quite insightful. So we can't thank you enough. I had, let's see, I'm looking down here. I had 17 questions that I was going to pose to you. You just answered about 14 of them. So I'm going to ask a couple of quick ones. Sure. You know, you and I have known each other for more than a decade, and I've always known you as a straight shooter. So we seem to be getting mixed messages from the president right now, and now, as of this morning, from our lieutenant governor. This whole issue about that the cure is worse than the cause. What's your take on this position?
Well, you know, my take is this, Ken, and, you know, it's kind of the same way I feel on Medicaid expansion. And I have to be careful because we treat Democrats and Republicans and hospitals. So what I'm going to say is not politically motivated at all. When I look at the Affordable Care Act and expanding Medicaid, it was to help people that were low income, potentially hovering right at the poverty level, have health insurance, some form of health insurance through Medicaid. That would help them hopefully get primary care, do things to prevent their illness from progressing to when they did finally show up at the emergency room, they weren't so sick that we wish we could have intervened upstream. As you know, that got into death panels, which was just so unfortunate. And then it kind of split down party lines as to whether we do it or not. I just never think that public health policy should be political. I really don't. Now, based on what President Trump is saying and based on what Lieutenant Governor Dan Patrick said, they're political leaders. They have every right to their opinion. I'm listening to the public health officials. If you talk to, say, Phil Wong here in Dallas County, or if you talk to some of the infectious disease doctors, or if you talk to some of the people that are the epidemiologists that have really studied this spread, I would have to say they are saying completely opposite, and I mean completely opposite of what you're hearing from President Trump and Lieutenant Governor. So I'm going to probably say I come down on the side of science, and I will support the public health officials, especially when I hear infectious disease physicians in our own hospitals saying we need to really flatten this curve and prevent the spread. And one of the best tools we have is to stay at home for a period of time.
Great. Thank you, Steve. So we all know we're in uncharted territories here, and we also know that there's a lot of research that's being conducted worldwide on the spread of this epidemic. So the question to you, Steve, is I'm going to ask you, not as a clinician, but based on all the research you've done, look into your crystal ball and let us know what you think when you think we might be back to normal.
You know, it's kind of hard to say. I do think this. I think that we are probably 4 to 5 weeks behind New York and Chicago. If I had to look at this as a non-clinician, I would say we're going to probably be in the thick of this through the middle of May or the end of May. Hopefully we'll be back to normal after the 1st of June, but that's my best guess.
By the way, that response is very consistent with County Judge Jenkins' response to that same question last week, although he did say don't feel comfortable planning large groups of people events until he thought at the very earliest late summer and potentially the fall.
Right.
So, but again, thank you for that perspective. I appreciate
Ken,
it.
this is Harsh. Do you mind if I ask a follow-up question on that, on your last question? Steve,
Sure.
what activity, I understand that there's a timeline of 4 weeks, 6 weeks, 8 weeks, but what milestone or activity needs to happen in that time that would bring us back to where we were 4 weeks ago?
I think what you have to see in discussing this with some of the public health officials is kind of what you're seeing in China now, where they had like no new cases, no more community spread. And so things could get back to normal. I think in that 4 to 6 week period, if we can see it peak and then start coming back down and we can say there's no more community spread, then I think we can use that as a point in time that we're beginning to get back to normal.
Steve, the other question is that I want to commend you and your hospital partners for penning that letter to the governor over the weekend. Steve also did an outreach to the business community in general and got a subsequent letter sent to the governor as well that basically outlined the same provisions and asking for the same actions. Can you tell us what you think might be the next steps in that process in terms of the dialogue with the governor?
You know, I never want to predict what a politician will do or what the governor would do. But I do think this, if you look at when Dallas County came out and said, we're going to shut down inpatient dining, and we're going to, Mayor Johnson canceled the parade, and all we're going to have is takeout at restaurants. It was kind of perceived by many throughout the state, wow, you guys are really, y'all are really doing some stuff up there. And then gradually you saw other municipalities do it. And then finally, Governor Abbott came out, as you know, and last Thursday he had an executive order where he essentially did the same thing. Let's minimize crowds. Let's shut down restaurants except for takeout. I really think as you see Harris County doing this, as you see Austin, San Antonio, Fort Worth, Dallas, Collin County, and so on and so forth, and many of the county judges, in fact, Hunt County, I think Hunt County has done it, and Hunt County is more of a rural county, which brings up a point I want to make in a minute. I would not be surprised to see the governor in maybe a week come out and say, okay, since most of the major cities and municipalities have done this, I'll just go ahead and do it statewide. Now, whether he'll do that, I don't know, but that would be helpful. Let me go back to the rural counties for a minute. The governor made a very astute remark Sunday when he held his press conference. He said, the reason I don't want to do this statewide is there are many counties that don't even have a single case. And he's right. I mean, nobody can dispute that. Here's the issue. They probably will. And in many of those rural counties, when that does occur, the ones that require hospitalization are probably going to come to major metropolitan cities such as Dallas, Fort Worth, Plano, and that's going to increase that volume that we're talking about. So if we could do stay at home now and prevent even those outlying counties, it would have a big impact on potential volume surges here in the Metroplex.
Great. So you had drilled down a little bit, Steve, on the capacity issue at your member hospitals and then the whole PPE concerns. And should we be building additional capacity right now like they're doing in other parts of the world?
Well, behind the scenes in emergency management, trust me, we're building contingency plans for expanding capacity. Portable type hospitals, using hospital space that is vacant now that was previously used as hospitals. Trust me, we're working on plans, and the cities and the counties' emergency management teams have done an excellent job. I will give them credit. And I'm not talking about just Dallas. I'm talking Tarrant, Fort Worth, Collin County, and so on and so forth. But Ken, the equipment is becoming an issue. Surgical mask. Yes, we're working, and some of the large group purchasing organizations have really increased capacity with some of their vendors. Here's the issue. This is the part. If it were only Texas, we'd get through this pretty easily. It's all over the country. Chicago needs surgical masks. New York needs surgical masks. New York needs ventilators. It's all over the country. So we're pushing hard. We're looking at alternatives. Construction companies have been fantastic, saying, hey, take all of our construction masks. Again, you got to make sure that they meet the clinical criteria. Maybe that would be good for someone in the waiting area that's admitting, more of a clerical job. But if they're directly treating the patient, one of those masks may not work because they may not have the breathable water or solvent resistance that you need in those masks. So, yes, supplies as this surge increases, assuming it does as predicted, and we don't know how some of these piecemeal closings we're doing and stay at home, they got to help. They certainly can't hurt. But we don't know what it's going to do to help slow down that surge. But PPE, medical supplies, ventilators, critical care beds, we monitor daily, and we're much more worried now than we were 3 weeks ago. Let me just say that.
Great, thank you. Jamie, you have a question. Why don't you unmute and ask your question to Steve?
Hi, Steve.
Hi, Jamie.
I was wondering about the hotels. There are many hotels in Chicago and California that are being used as quarantine hotels. Do you see that as being something that might cause a resurgence of the virus once they reopen as a regular hotel again in the future?
Well, I hope not. We are looking at hotels too. Potentially, we're working through our Department of Management. If we use those, they would be properly fumigated for sure before they reopen. But I know what you're saying, Jamie. It's kind of that psychological approach about, man, I don't know if I want to go there because that's where the coronavirus was. We understand that. But again, I think we have to look at public health, listen to the scientists and the people that really look at this. This is so much different. We had Ebola. A lot of people didn't realize this, and I know there was a panic with Ebola. Overall, North Texas did such a good job of containing it. Ebola is not as contagious as hepatitis C. You can get hepatitis C easier than catching Ebola. This, unfortunately, even though only about 20% of the people have to be hospitalized, those people are really sick. What the infectious disease doctors are telling me, this is more contagious than the flu by about 4 times. So it goes through the population quicker. And the thing I haven't brought up, and I'm not a clinician, but Zika, you remember Zika? When everyone was worried about Zika, especially if you got the Zika virus from a mosquito and you were pregnant, they actually found out about a year later, even people that weren't pregnant, there was some additional side effects that came with Zika. I actually worry, but I'm not an infectious disease doctor. Are there going to be any long-term side effects that affect people that get infected with this virus, even if they're not hospitalized and they seem to make a recovery? I don't know. There's still a lot to be learned about this virus.
Steve, we have a question on blood supply. Seems to be there's a blood shortage as well. Would you recommend people leave their homes to donate blood? Isn't that an essential activity?
Yeah, that's a good question, and I'll double check. I think giving blood is an essential activity. Here's the issue on the blood drive, and a lot of people don't think about it. I had a long, detailed discussion with Dr. Merlin Sayers, who, as most of you know, runs Carter Blood Care, and he was actually on our radio show this past week. Many churches, many synagogues, many religious groups hold big blood drives. Believe it or not, a lot of schools, especially if you have seniors that are age 18 and older, give blood. Many of those activities are now shut down because obviously they can't meet. It's not just Carter Blood Care, same way with the Red Cross. We are going to have a blood shortage because we aren't getting enough blood. Now, Ken brings up an excellent point. Carter Blood Care has 26 locations where they have Carter Blood Care blood donation centers, and they'll take reservations so that on a large group of people in the waiting room. So if you call and make a reservation and go and give blood, and then you come back home, that would be excellent because, as you know, we're all focused on this virus, but there are still car accidents. There are still people that have other illnesses. Blood is a precious commodity right now, not only here, but throughout the nation. A couple of things that Dr. Merlin Sayers told me. If you give blood, can you transmit this virus to the recipient? The answer is no. It's no different than the flu. If you had the flu and you gave blood, whoever got the plasma or the blood you donated, this virus does not survive. So he wanted to dispel that myth as well.
Steve, I'm going to call on one of our favored people within the chamber, the chair of our Public Policy Council, Dev Rastogi. She has a question for you right now. Dev, you want to unmute? Well, if she's not available to ask her question, I'll ask it for her. So this is from Dev Rastogi of AECOM. And the question is, as we think about the future and fears related to large gatherings, traveling, etc., are there things we need to do to educate and protect the public from other viruses?
You know, that is an excellent question. And let's go back to the flu, because, you know, we take the flu shot, but you know you can still get the flu. I think people have learned some good health habits. I think when we get through this crisis, and we will get through this crisis, hopefully people will continue to focus on washing their hands and washing them very thoroughly and using hand sanitizer. I have a friend of mine, when they get on the plane, they work here in our foundation. When they get on a plane, and this was before this virus, they have Clorox cloths that they clean the tray that you can put down, and they clean the hand rest. And when they get to the hotel, when they're traveling, they clean the remote control and they clean the doorknobs of their hotel room. And you may go, well, is that overdoing it? I'm not sure it is, but that would help hold down on other viruses. So maybe, if nothing else, a silver lining, if you will, in this is a real focus on personal health and taking care of ourselves to prevent other viruses that we pick up. That's a great question.
Dr. John Grabarczyk, a good friend of the chamber as well, from the University of Phoenix, has a question. John, did you want to unmute and ask it, or did you want me to ask it?
I can ask it. Thanks, Ken. Yeah, Steve, there was some conversation about when the temperatures warm up, that'll be better, help in the containment. Is there any perspective on that, on warmer temperatures helping?
Yeah, you know, again, I'm not a clinician, but I've been asked that question so many times. I sat down with 2 infectious disease doctors that I really respect. And I said, and one of these used to work at the CDC. And I said, I asked the identical question, and they said, we really don't know. We really don't know if when we get into the summer, it's going to be kind of like the flu. And what we also don't know is what I said earlier, even if it does subside, is it going to recur next year like the flu? And so we're going to have to come up with some type of vaccine where not only do you get a flu shot, but then you get a shot also related to COVID-19. So, John, I wish I had a better answer, but all the infectious disease docs I've talked to are very hesitant to answer that in a way that would say definitive one way or the other.
Thank you.
Steve, we have a question from Harsh Agarwal, our board representative from the Bank of America. Harsh?
Thanks, Ken. Steve, I'm curious to learn, you mentioned at the start of the call that we've had previous coronaviruses with SARS and MERS. What makes this specific virus different from the past viruses that we've gone through? And any thoughts on what we can do today over the next 12, 18 months to make sure that, or to at least prevent something like this in 5, 10, 20 years time frame?
I'll take the second part of the question first. I'd really have to ask an infectious disease doc on what we could do to prevent this in 12 or 15 years. I will tell you, based on my limited discussion, this is what they tell me. Even when you go to the coronavirus, and and this is where people have been misled when they said, oh, the coronavirus, it's the common cold. Well, there is one type of coronavirus that's the common cold. But as I said earlier, another one really deviated, found a host in a bat and became SARS. So you really couldn't, it was almost like it mutated and went into the bat and then came back to the human. In the Middle East, as I mentioned, MERS is a deviation or a mutation off of that SARS, and it went to a camel and it came back. Now, I don't pretend to be an infectious disease specialist. What one of them told me is in SARS, we rushed, and 14 months later, we came up with the vaccine, and SARS ran its course and pretty much has never reoccurred for the most part. So they did develop the vaccine, but they don't need it. They don't know if that's what's going to happen here, that maybe 12 months from now we come up with the COVID-19 vaccine. Will it reoccur, or is it going to run its course? The way they explained it to me, anytime a virus can mutate, find a host, and then come back. There's actually some people, Wuhan, as you know, has large fish markets. There's some people that think that maybe the intermediary, if you will, that this jumped to was a fish and it came through seafood. Now, most of the infectious disease doctors I talk to don't think that. They think it's probably something like a bat or something along those lines. I really can't answer that better than that, and it's not a real good answer, but that's what the infectious disease docs have told me, and that's why it's hard to look 12 or 15 years ahead and say, what do we have to do to prevent something? We're not quite sure what form it's going to take and what the intermediary is going to be.
Thanks, Harsh, and thanks, Steve. So Jeff Kittner just reminded me, I had a question for you, Steve, that, we have a lot of focus. I mean, almost exclusively our focus today is on COVID-19. How is that impacting your ability to create a robust legislative agenda for 2021, and particularly relative to Medicaid expansion?
Well, I think there's 2 points that would be good to point out, and we plan to point out. You hate to do it right in the middle of a crisis because it looks like you're taking advantage of the situation. But I am going to use this to remind our state legislators, wouldn't it have been nice had we expanded Medicaid back when the Affordable Care Act first came out? Maybe it would have helped in that some of the people that got infected with this virus potentially may not have. And even if they did get infected, they may have been in pretty good health. They could have fought it off and not necessarily ended up in a hospital. The other thing that I plan to use this for, this is a great example of a catastrophic drawdown on state resources. Had we been on a Medicaid block grant where you get a fixed amount of money and that's what you get and you have to make it work, I've always said if you have a catastrophic event such as a hurricane, or in this case, this virus, you would go and hit a limit on those federal funds, and then the state would have to pick up the tab. We just said, hey, let's draw down as much federal funds as we can. Let's do this. If you were under a block grant, there's a good chance the answer would be, we gave you your block grant, you've got to make the rest work. So I'm very leery of block grants for that very reason. And I think that would be 2 great examples how we take this and look to the future and try to advocate in a positive way to make some changes in how we deliver Medicaid.
Steve, just a couple of other quick questions. One, from a federal perspective, I'm sure you've been examining the stimulus packages that are being considered in the Congress right now. What's your position? What's your association's position on the amount of dollars allocated for healthcare in general, and as well as for specifically hospitals in these stimulus packages?
Yeah, in the stimulus packages, and I certainly won't get into the other economic, the banking industry or any of that, but in the healthcare part, thus far, the American Hospital Association, which represents all the hospitals in America, obviously, has done a pretty good job. we're not in there trying to get more than we deserve, but the American Hospital Association has done a pretty good job of laying out, like additional funding for the increase in PPE cost. Not that anyone is price gouging, some are, but there's going to be an increased demand. There's going to be some normal inflation on how they help with that, how they help with some of the extra expense associated with workforce, some of the extra expense that we've got. I think in the stimulus package thus far, what's been earmarked to help healthcare has been fair, it's been equitable. The proof is in the pudding, and that's when the actual checks get written.
That's great. Well, we have another question from someone who's near and dear to you, a renowned PhD from TWU. And do you want to ask your question, Marie? Well, I'll ask it for her then.
I'm unmuting. Thank you.
Thank you.
So at TWU, we teach telehealth, and we have since 2013 because we saw the need for that for the rural communities. Now we're seeing a surge in telehealth services. In fact, CMS yesterday removed all restrictions for providers who wanted to provide those services and treat their patients in a telehealth framework instead of the traditional, and actually gave them the CPT codes and codes to actually bill for it. So I was wondering if you're seeing anything about that in the Dallas area. I'm seeing it more nationally.
Yeah, definitely in the Dallas area and in our rural areas. There is a lot of the telehealth that we had in place, and it's being expanded more. And I'll tell you, along telehealth, one of the things that really has been astounding, most of our hospital systems have put virtual screening in place. And many of the hospitals put this up really about 10 days ago. And what the virtual screening is where you go in and virtually, either through an app or on their website, you go through a series of questions. Are you running a fever? If so, what is your fever? Is it over 100.4? That's kind of the point they look at, 100.4. Second, do you have respiratory issues? Do you have a deep and heavy cough? Are you experiencing shortness of breath? Have you traveled, and they'll show the countries, China, Japan, Italy. But even more importantly, how long have you had these symptoms? Then they assess your risk, and it says you're low risk, high risk, etc. And if you're in the high risk, sometimes you click and you're connected directly to a primary care provider that's within the hospital system, or they give you a number to call. You then have a discussion with them, and they may tell you, you need to come in for testing, and we will write an order so you can come in for testing. And that went up, and I checked last week, and we had already had close to 200,000 people in North Texas use that at our hospitals, which brings up another point. I know everyone wants to be tested. Please don't come running to hospitals and say, hey, I want to test, unless you're running fever and unless you've got those symptoms I went through, and unless you have truly been exposed to someone who is tested presumptive positive or positive for this virus, you probably aren't going to be given a test. Great question, but telehealth comes into play. And I'll tell you the other way telehealth is helping. Many of the people are anxious. Many of the people are panicked. And from a behavioral health, many of our people are using telehealth to help calm people down and say, hey, let's work through this. We don't think you have the virus, but here's some good behavioral health, positive mental health exercises you can do. Thanks.
Steve, last question. How are you doing? And you know, you've always been so great to us over the years. What can we do for you right now?
I think what you can do is not so much for me, is for our first responders and also our nurses. If you know any personally, just shoot them a text, shoot them an email, say, we really appreciate you. I think anything you can do to let the medical community know how much you appreciate and respect the fact that they're on the front line would help morale. Also, it would help them. I'm not at liberty to go into something, but you're going to see something in the next couple of weeks that is going to really make you feel good about the hospitals in North Texas. I can't tell you now, but it's going to really make you go, this community cares about its people.
Great. Steve, we can't thank you enough. You're helping us inaugurate our series of remote editions. As a result, we'll be making a donation in your name to the North Texas Food Bank in recognition of your contributions today. And I also want to thank all our two sponsors, Iberia Bank and Encore again, without whom we couldn't provide this type of programming. And I want to encourage you to check out our website for all future remote edition programs. And while there are many of them that are being scheduled as we speak, we're adding new programs almost every day. I want to bring to your attention our next one, and that'll be on Friday at noon, and it'll feature Dr. Richard Benson of the University of Texas at Dallas. Thank you, Amanda Rockow, for making that happen. And he will be talking about the impact of COVID-19 on the higher education space. So thanks again for everyone's engagement and continuing support of the North Dallas Chamber of Commerce. I'll close with a quote that I gave to our board in our first virtual board meeting, and that is that the challenges that we face now will eventually pass, but the great work of the North Dallas Chamber of Commerce will endure. So best wishes to all of you. Stay healthy, stay distanced, and we are adjourned.